So we're going to talk of shoulder and elbow. I am a consultant orthopedic surgeon. I work in Liverpool, but though I'm an orthopedic surgeon, I'm 61, and my practice is yes, I still operate, but only on fracture neck of femurs. Majority of my practice is trying to help people without surgical intervention because I think the pendulum has swung too much into surgery. Just like medicines. 10 tablets in the morning, 10 tablets in the afternoon, and 10 tablets at night. Whom does it benefit? Does it benefit the sufferer of the problem, or does it benefit the company, that the shareholder of the company that makes the tablets? So same way, even surgery, is it all the surgeries relevant? Should we be doing it? I'll show you a very interesting case as we end today's webinar. Towards the end, I'll show you a very interesting case. A lady who's had numerous operations, and it's a very interesting case. Okay, so let's start on the shoulder and elbow now. So we are going to do a little bit on anatomy and basic science, just not everything in anatomy, just a few points. Then we are going to look at a few conditions and how to diagnose them by examination, and a few pointers on exercise therapy. But sometimes where surgery is required, I will mention that, and we'll look at the outcomes, what can be achieved by the different treatment modalities. So that is what we are going to be looking at. So in the beginning, let's start with basic science, anatomy. So, and we are the conditions that we are going to look at 6 conditions. We are going to look at rotator cuff tendinopathy or rotator cuff tears, shoulder impingement syndrome. We're going to look at frozen shoulder, then shoulder instability and dislocation, then osteoarthritis of the shoulder, and in the elbow, we are going to look at tennis elbow and golfer's elbow. Tennis elbow being lateral epicondylitis, and the golfer's elbow being medial epicondylitis. So this is the shoulder. So the shoulder forms of 3 bones: the clavicle, that is the collarbone, the shoulder blade or the scapula, and the humerus, which is the arm bone. And the main joint is the glenohumeral joint, that is between the scapula. The glenoid is the scapula and the head of the humerus. So that's the main joint, the glenohumeral joint. But there are some accessory joints. You have the acromioclavicular joint, the sternoclavicular joint, and there is also a thoracic scapular joint. It's not a full real joint, but the scapula moves over the shoulder. And sometimes in some people, the scapula doesn't move over the shoulder, and that may be the cause of multidirectional instability. We'll come to that. So because when we lift our arm up, it is only 50% of the motion. 90 degrees comes at the scapulohumeral joint or the glenohumeral joint. The 50% is the scapula moving on the shoulder, on the thoracic chest cavity. Now, it's just a diagrammatic representation from the cross section of the shoulder. So this is the front, and this is the back. So what is important here is these are the muscles and the tendons around the shoulder. Now, throughout the body, the way nature has arranged it, there are small muscles on the inside and large muscles on the outside. The work or the function of the small muscles is to hold the joint. They are the stabilizers, where the large muscles are the movers. So here you can see this, the top here, the supraspinatus, the infraspinatus, the teres minor, and the subscapularis in the front here. And that is, I put a yellow circle around it. So they are the small muscles, and their job is to hold the ball into the socket. On the right is the front, and on the left is the posterior aspect. But the other muscles, the deltoid that you can see in the front and the back, then you have the pectoralis major, the teres major, and the biceps. They are the big muscles. There's also latissimus dorsi, but latissimus doesn't come into this cross section. Now, these are the big muscles that actually move the shoulder. But those muscles can only work if the inner muscles are holding the ball into the socket. If the ball is not being held into the socket, then the large muscles can't work. And that is why when we have a small tear in the supraspinatus, and the supraspinatus can tear, because you must understand this is the neck of the scapula, that is bony part, and the head of the humerus, and over here you have the acromion. So the supraspinatus is sort of sandwiched sandwiched between two bones. So when it is sandwiched and when we move the arm, there is a lot of friction that can occur on it, and that is how, and there is also not a great area for blood supply, and that's how there can be a tear of the supraspinatus tendon. So that green area is the bigger muscle, and they are the main movers. So the yellow area borders the smaller muscles or the stabilizers, and the green area, shaded green, are the large muscles. Those are the movers of the shoulder. Then this is the elbow, because we are also looking at the elbow, made of three bones. So you have the humerus and the ulna and the radius. And when you look at it from the front, this is the humerus here, the radius is on the outer side, and the ulna is on the inner side. The bigger joint is between the capitulum and the ulna, because that is a much more greater surface. The interaction between the radius and the lower end of the humerus is a smaller surface area. But because it is a smaller surface area, though it is a smaller surface area, it takes most of the weight. 55% of the weight of the shoulder goes through the outer aspect of the, sorry, in the elbow, goes through the outer aspect of the elbow rather than the inner aspect of the elbow. So that is why arthritis in the elbow usually starts from the outer aspect and not on the inner aspect. Now, a little bit on biomechanics and exercises. There are three types of exercises we are going to look at. So, the one type of exercise is stretching. Now, in some conditions, we need stretching, but generally, I personally prefer strengthening. But things like frozen shoulder, which we are going to look today, stretching is important. But otherwise, overall strengthening is important, and strengthening is very important because there is a lot of evidence to show that strengthening provides better outcomes. Stretching actually doesn't. There is an innate feeling that stretching helps. Like all of us want to feel the feel good factor that you can stand up, bend forwards, and touch our toes. But there is no evidence that if you can stand up, bend down, and touch your toes, it makes you less heart attacks or more less chance of back pain. There is no evidence. Whereas if your strength, you're strong enough to do a plank, then the chance of disc prolapses, or if you're strong around your shoulder, then the chance of dislocation or arthritis is less. So it is the strengthening that matters. But I want to introduce you to a new type of exercise, and I will show a short video so you can understand that. It is called eccentric exercise, and that is, we do that when we have tendinopathies like the tennis elbow or the golfer's elbow. So that is me in my scrubs, or tunic rather, not scrubs, tunic, and you can see me doing the eccentric exercise. Now, this is how you do the eccentric exercise. I'll let the video run for a short time and then I will explain it to you. So imagine I've got tennis elbow in my left arm. And if I have tennis elbow in my left arm, my pain is going to be on the outer side here. So this, just an ordinary rucksack. And what I've done is I've, inside the rucksack, I put two bottles of 1 liter water bottles. You can change it. If someone can't use 1 liter water bottles, you use 1 liter water bottle, or even half a liter of bottle. Now, if you do, there are two types. There is a concentric movement and an eccentric movement. So as this bag is lifted up, there is a concentric movement of the extensor muscles. Now, if I just do concentric movement, my tennis elbow will become worse. Whereas if when I'm lowering the bag down, it is an eccentric movement. So the treatment for tennis elbow is to do eccentric stretching. So if I lift it up with my left hand, it will make my tennis elbow worse. So when I'm lifting, I'm using my other hand, the good hand, to help me lift the bag up. And then the bad hand, or the left hand, which has got tennis elbow, is allowing it to go down. So let me repeat that video once again. You will see with the good hand, I'm helping for me to lift the weight. Then the bad hand is helping it to go down. So the good hand helps it to lift, and the bad hand. So while it is weight bearing, so eccentric means it is extending while it is weight bearing. So that is the meaning of eccentric. Concentric means it is contracting while it is weight bearing. So lifting up would be constricting the extensor muscles. So in that you need the help of the other hand, but for lengthening you need you just do it to the arm that is affected. We will look at that once again later. Then coming to the particular conditions, so let's look at the impingement. Now, as I said, this is the head of the humerus. This is the scapula. There is a very tight space. This is bone on the top, that is the acromion. There is a very tight space, and the supraspinatus muscle comes from the back of the scapula and inserts here. So it is basically that little tendon is sandwiched, supraspinous tendon sandwiched between the head of the humerus and the acromion. So obviously there are, it can get, friable, and it can get, micro tears can occur on it, and also tendinopathy, or sometimes it is just inflamed, that when you say there is impingement, or you can have a small tear, and there is unfortunately a bursa there to allow for the smooth motion. Bursa is like a sac which fluid there to allow lubrication and for the movement, and that bursa can get inflamed also. So that is the anatomy of the impingement, what happens in impingement. The way to diagnose it, one of the ways is the near sign. You hold the arm at 45 degrees away from the body, and then lift it upwards into 135 degrees. And when you lift it upwards, when you reach this position at 135 degrees, they may experience pain in the shoulder, and then you say impingement is positive. And this is the Neer's method of saying impingement is positive. But there is also another method called the Hawkins-Kennedy method. Again, you abduct the arm, bend it at the elbow, and internally rotate the arm, as you can see me do that. And when you internally rotate the arm, the greater tuberosity hits on the acromion, and if the acromion is exposed or is very inflamed, you're going to notice pain. So that's again an impingement sign. Then there are some special tests to see whether there is tendinopathy. You would have known this as the thumbs up test, where you put your thumbs up, and that is testing your supraspinatus. It is also called the full can. Imagine you're having a can of Coke. So when it's a full can, you hold it in this way with your thumb pointing up, and that way you resist the movement. Ask the patient to lift up. You are holding the hand to resisting that movement, and if there is pain, then you know there is supraspinatus tendinopathy. And similarly, there is a thumbs down. So you ask the patient to put the thumb down. So it's like the empty can, as if there is no Coke in the can, and you're emptying the can. And in that position, ask the patient to lift the arm in this one third, in an angle of 45 degrees between the coronal and the sagittal plane. And then if they have pain, then you think it is either the supraspinatus, sometimes the infraspinatus also may be involved. The next tendinopathy test is resisted external rotation. You ask the patient to keep the arms by the side of the body, and ask them to do an external. They are moving it outwards. They are, trying to take their forearms, pointing to either side of their body, but keeping the elbow to the chest. And if that movement is painful, then you suspect that the infraspinatus or the teres minor. So this is the back of the shoulder. You can see this, the spine of the scapula. Above the spine is the supraspinatus. Below the spine is the infraspinatus, and below that is the teres minor. So those four muscles are the muscles around the other rotate cuff. And now we are looking at the front. This is the front of the scapula, and you can see the subscapularis muscle. Now, the subscapularis muscle allows for internal rotation. And here we are testing resisted internal rotation. Ask the patient to keep the hand over their lower back, and then ask them to lift off the lower back, push it backwards. So you put your hand on top of the hand to prevent them from doing it. So you're giving some resistance to the lift off. And if that movement is painful, then you suspect that there is if it is weak, there is a tear in the subscapularis. If it is painful, there is a tendinitis in the subscapularis muscle. There are also tests to identify the biceps. Biceps is also part of it, not the immediate rotator cuff, but biceps can be involved. So you do the speed test. In the speed test, you keep the arm forward and you're asking the patient to lift the arm, whereas you're providing some resistance. And again, they will feel pain where in the front of the shoulder where the biceps tendon is. And you can also do the Yergason's test. You support the elbow and the forearm, and you ask the patient to keep the hand pronated, and the pronated meaning the palm facing the floor, and ask them to supinate it, turn the palm so that the palm is facing towards the sky. And if that causes pain, then we think it is the biceps tendon is involved. Now, all of us have heard there is a lot of operations being done called arthroscopy for the shoulder. So, arthroscopic subacromial decompression, whereby if there is a problem in the shoulder, either from impingement or if there is a rotator cuff tear, they do an arthroscopy. And sometimes the tear is not repaired. You just need to decompress. Meaning, if I go back to if as I showed you, you need to take a little bit of the acromion off, a little bit of the clavicle off, and give extra space for the supraspinatus tendon. So you can do it arthroscopically. So this was a trial done in the UK, and they were looking whether the arthroscopy would work or not. So this is called the Seesaw trial, Seesaw, CSAW trial. And they recruited some multicentric trial. They recruited 313 patients, and they were divided on a 1:1:1 ratio. So 106 patients, so there were three arms to the trial. So one set of patients just got the decompression. So they had the arthroscope inside the telescope into the shoulder, and the bottom part of the bone was shaven off. The next group just had the arthroscope, nothing was done, put the arthroscope in and take out just like a placebo. And the last group had no treatment at all. They had one session with the physiotherapist, and then they were discharged and only to be seen in follow up. Now, you would think if arthroscopy and decompression was that good, the people in this group would do extremely well. But that is not what happened. What really happened was all of them did very well. The arthroscopy did well, the decompression did well, and people who had no treatment also did well. So, and in the end, the difference between people who had the arthroscopy and decompression to people who had no treatment was not statistically significant at all. So there was no difference by doing the arthroscopy, and the minimal difference was not statistically different. So, when you look at cost wise or even complication wise, it is not worth the doing this surgery at all. So arthroscopy has no benefit in many of the just shoulder pain, and just doing physiotherapy and treatment is all, strengthening exercises is all that is required. So next we come to the rotator cuff tear. So I said the tendinopathy is where there is inflammation. Is there any questions at this point? I want to make sure that everyone is.
No, there's none. Oh, sorry. Someone's asking about the black blocks that are obscuring some of the print, please, George.
Sorry, what is
You, you,
skewing?
you can see some black sort of blocks as you're showing your slides, and you've been moving them around, but they're obscuring some of
Oh,
the.
that is my question and answer. Okay, I will close it. Yeah.
Okay,
Okay.
thank you.
Yeah.
Other
Yeah.
than that,
Sorry.
we're all good.
Okay, fine. Thank you. Yeah. Yeah. So next we come to the rotator cuff tear. And as I said, we looked at tendinopathy, where usually again the supraspinatus muscle is the one that is usual culprit. Sometimes even in the tear, the usual culprit is the supraspinatus tear. And you can see that there is, figuratively, I've shown how the supraspinatus can tear. And that is because it may get chaffed between the bone at the top, the acromion, and the ball. So this is the ball and this is the socket here, but the acromion is an outrigger of the scapula and the clavicle, and that is where it gets chaffed and how it may have an injury there. Now, this is an MRI scan of supraspinatus tear. So this is the coronal section. You can see this is the glenoid or the socket. This is the ball, the top of the arm bone. So this is the ball and socket joint. You can see the acromion come in here. And this is the supraspinatus muscle. You can see this gray structure coming and inserting into the the lesser trochanter here. And the tear is what is shown by the red arrow, the two arrowheads, and you can see that there is a small tear. So this is only a partial tear. And this is the coronal section on the right, and you can see that that coronal section is how wide it is. So you can measure. The white shows that there is fluid inside. It's a T2 weighted scan, and you can see that there is a small tear in the supraspinatus tendon there. And again, if you take an MRI scan, this is an MRI scan slightly more inside into the shoulder because you want to see the condition of the supraspinatus. So this is more, you're going more inside near the chest wall where the scapula is. So this is the scapula. This is in the front, the coracoid, the acromion at the back, and this is the supraspinatus muscle. And in this particular scan, you can see that the supraspinatus is reasonably bulky. So exercise should potentially help, without any intervention. And if you look at the Cochrane's study, Cochrane, what do they recommend? Now, they recommend, so they have looked at 9 trials with 1,007 participants. And their suggestion at the moment, we are uncertain whether rotator cuff repair surgery provides clinically meaningful benefits to patients with symptomatic tears. It may provide little or no clinically important benefits with respect to improving function, overall quality of life, pain, and participant rated success when compared with non-operative management. So again, it shows that Cochrane studies, you don't need to do an operation. You can treat it with exercises, and potentially that would give us the good benefit. Sorry, I'm giving you different trials, but I thought it is important that we are looking at scientific evidence or evidence base. This is the GRASP trial, again done from Oxford, a very good trial. And the GRASP means getting it right, addressing shoulder pain. And Sally Lamb was one of the main authors of it. And you can see progressive exercise. This is for just shoulder pain. So anyone who had shoulder pain were involved in this trial. And here they did a very interesting thing. They did a 2 into factorial randomized control trial. 2 into 2 factorial means that you have, you can construct a 2 into 2 table. So some patients had steroid injection and also had exercises. With the physiotherapist, 6 sessions with the physiotherapist. Some patients had the steroid injection and had just 1 session with the physiotherapist and then did the exercises at home. So one set of was steroid injection or no steroid injection. The other set was progressive exercises, 6 sessions with the physio, or just best practice advice with 1 session with the physio and an exercise sheet given. So there'll be 4 groups. So one group having steroid injection and progressive exercise, another group steroid injection and best practice, another group no steroid injection and progressive exercise, another group no steroid injection and best practice. So there are 4 groups. And so this is how the 4 groups, and this is how the numbers were. In progressive exercise, there are 174. There were over 20 centers in the UK. They totally recruited about 788 patients. And in the best practice advice, that is 1 session with the physio and discharge with exercises. And some were given corticosteroid injection and the same 6 sessions with physio. The others were given corticosteroid injection, steroid injection, and was given best practice. That is 1 session with the physio and a leaflet to go and do exercises at home. So again, they found that at the end of 12 months, they looked at different outcome measures. There was no evidence of difference in SPADI score between all the 4 groups. There was no evidence. So between the best practice and progressive exercise is 6 sessions with the physio. Best practice is 1 session and a sheet of paper. Similarly, no evidence of difference between corticosteroid injection with and without. And there were no serious adverse events reported. So basically means getting a sheet of paper, doing the exercise at home, or if you're giving the exercise, sorry, Amanda, you raised your hand.
Sorry to interrupt you, George. We can still see these black blobs of like the black blocks. They're covering some of the text, please. So
Oh,
there's like one at the top that's parallel to the screen, and there's one at the bottom that's like covering your logo, but it's distracting some of the participants. Can you see it,
the
George?
yeah, is it now moved to the top, or because one is all the three, uh, 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 the
That's
panelists on the
better. That's
top.
better. Is that okay for everyone? Yeah, I think it's come back again now, George. It's in the middle of the top sentence. That's
Is that better?
better. Yeah, that's better. Brilliant. Thank you.
Okay, yeah. Thank you for highlighting. Yeah. And there were no adverse events reported in any of the groups. So basically, just a set of exercise. And what were the exercises they gave? It was a very simple sheet. So they had a ladder of exercises. So one of this, we will go through some of the exercises later. So is that, patient is asked to sit on a table, have a towel by the side so the towel can slide. You put the arm on the hand on the towel and you lean forward, lean to the side, and as you lean to the side, you're stretching the shoulder out. Same way, you keep the towel in the front and push the towel forward and then lean forward. Again, you're flexing the shoulder, you're abducting the shoulder. Then you can do resistance against rotation. So you can either hold with a hand or you can stand by a wall and turn your arm outwards, or you can have you can outward movement, that is abduction against. Here you can see the lady is on her using her arm and preventing the arm from the bad arm from going outwards, or standing by a wall and preventing the abduction, sideward movement. Here she's using a resistance band and turning outwards. Here she's sliding again using a towel, folded towel, sliding up a wall. Here she's using a supported way and with a resistance band and doing an external rotation. Here she's using weights and then lifting the arm. Here she's cross arm with a resistance band. This is the highest. But you don't need to do what they were doing is you don't need to do all the exercises. You do what you can. And just by doing and encouraging the patients, they were getting benefit. And whether they had an injection or not, or whether they had 6 sessions or not, it made no difference. So the patients, if they are motivated and they can do the exercises, that was giving them enough benefit. Then the next condition we are going to look at is a frozen shoulder. The frozen shoulder is where suddenly there is pain and there is fibrosis and the shoulder doesn't move. So there are different phases of it. A frozen shoulder will settle by itself. If given time, either 2 years or 3 years, the frozen shoulder will just settle naturally. So there are three phases. The first phase is anything from 2 to 9 months. The second phase lasts from 4 to 12 months. And the last phase lasts from 5 to 24 months. Initially, it is increasing pain. In the freezing phase, there is increasing pain. That is for anything up to 9 months, but it could be shorter. Then in the frozen phase, the pain decreases, but stiffness increases. And people with frozen shoulder find it very difficult to sleep at night, and they will not be able to lie on the side of the shoulder that is painful. And then if when the frozen phase, yes, the pain decreases, but they don't have the movement. And after about 12 months, 14 months, they start slowly, the movement improves, and then it just naturally returns to full. Maybe there will be some restriction finally, but you nearly reach the full range of motion in about 2 years. So it is a self-limiting condition. But during those 2 years, there is an issue. So there are many treatments, but the easiest treatment is give them exercises and for them to do exercises. So these are the range of motion you try to test them in. Abduction is a sideways movement. Forward flexion is lifting your arm forward. External rotation is keeping your elbows by the side of your chest and moving your forearms outward. Or internal rotation is scratching the back with with one or both your hands. So these are the range of motion, and there'll be restriction. The greatest restriction will be in abduction and external rotation, and that is how you identify. In Middlesbrough, they did this UK, they were the center of the research, and they did the UK Frost trial. It was led by Amarengan, and Frost is the frozen shoulder trial. And again, it was something similar what they did. They took 503 patients, and out of the 503 patients, some had early physiotherapy, given a sheet of exercise, go and do the exercise. Others had anesthesia and their shoulders were manipulated because it had all frozen up. The third group had arthroscopy, so the telescope was put into the joint, and the inside there was release, cuts made in the joint so that it loosen up, because it is all fibrous. It's like a double-breasted coat being put too tight. So they cut off so that it will become loose. And they recruited in 35 hospital sites, and there was robust evidence. But again, what did it show? All the three groups, whether they had early structured physiotherapy, whether they had manipulation under anesthesia or arthroscopic capsular release, all of them did similar, and there was no difference at the end of 12 months, all the three groups. So then why needlessly do an arthroscopic capsular release, or needlessly do a manipulation under anesthesia? The outcome is the same for all the three groups. So the exercises they gave were something similar. It's there on a YouTube link. I can send you the YouTube link. So place the arms on a table, and as you bend down like this, you're stretching, so you're elevating, you're flexing the shoulder forward, but you're not lifting it up. By bending forward, you're slowly increasing. You don't need to do it to the limit. You just feel a stretch, and you hold the position for 15 seconds and repeat it 3 to 5 times. Similarly, you want the external rotation. So you fold a small towel and hold it between your arm and your chest. You use that towel because you don't want to move your arm away from your body, because your elbow should be kept close. Otherwise, you'll be lifting your arm off, and there'll be a false movement. You only want a pure rotation. So that is why you have to still keep the towel under your arm, and then you, with a walking stick or something, you push your arm, so from neutral to external rotation. Hold it at 90 degrees, hold it for a count of 15 seconds, and then release it and repeat it 3 to 5 times. So that's external rotation. The other one is either you can do it sitting, standing, or lying down. You clasp, like how the lady on the top left, you clasp the hand on the back of your head, and then slowly move your elbows outward so that you're stretching. Again, you only need to do it within the limits of pain. Hold it for 15 seconds, release it, and repeat it 3 to 5 times. These are the exercise given. The other one is taking a walking stick, holding it behind your back like the picture on the left, and then slowly lifting it up, and that way stretching the shoulders and increasing the internal rotation. Again, you only do it up to the limit of your pain. Hold it for 15 seconds and then repeat it 3 to 5 times. So these were the exercises they were given, and you were told to do it 5 times a week. And generally, when you advise patients to do the exercise, you ask them to do exercise for 5 times a week, but it is important they don't have 2 days off at a time. It should be 3 days, 1 day off, 2 days, and 1 day off, because it should be non-consecutive. The 2 rest days are non-consecutive, because you need to be exercising regularly. You cannot take a full weekend off for exercise, only 1 day off for an exercise, but you can take 2 days in a week, but split. Then coming to osteoarthritis, this is where there is arthritis. There is not. It could be both an inflammatory arthritis or osteoarthritis, but together they finally form secondary osteoarthritis. It is arthritis in the shoulder is much less than the arthritis in the hip and the knee. But there is still, there are 32% of the adults will have arthritis in the shoulder, and for 4% it is symptomatic. It is, quite painful. And the reasons can be primary. It can just happen. It can happen following injury or trauma, or there could be rotator cuff tear arthropathy, and I'll explain that in a minute. I've got some x-rays. Or there may be inflammatory arthritis, meaning rheumatoid arthritis or ankylosing spondylitis. Or there may be avascular necrosis, meaning the blood supply to the head. Sometimes some people who do deep sea diving, they may get avascular necrosis or too much of alcohol or steroid. And infection or septic arthritis, and also in people who use painters, roof, people who put painting the roof, they have overuse over the above the shoulder level activity. Increased activity can also have an increased chance of having osteoarthritis in the shoulder. So there are again exercises, progressive shoulder exercises in glenohumeral osteoarthritis, and there is some benefit. And again, strengthening exercises do help. But I'll just digress to just show you a little bit of surgery that can be done. I know it is mainly non-operative, but so that information is passed on, and I want you to give in the feedback whether you'd like that extra bits of surgical information that you received. So now these are in both these shoulders, there is arthritis, but there is a completely different sort of arthritis. On the left, if you see, the arthritis is where the cartilage goes. So this is the arm bone, the humerus, and this is the ball, and this is the glenoid or the scapula. So there is no cartilage here. There is loss of cartilage here. Similarly, there is loss of cartilage here. But there is a difference between this picture and this picture. What is the difference? In this picture, the rotator cuff is intact. I told you the small muscles that are holding the ball into the socket are intact, and hence the ball is still in place within the socket. But here, the rotator cuff is completely damaged. The supraspinatus is completely gone. And because of that, the deltoid is coming down and pulling the shoulder up. And that is how you can see the ball has migrated up and hitting on the acromion. So this is with rotator cuff arthropathy. This is arthritis with the rotator cuff is intact. So when you have here this, you can have a total shoulder replacement. Here you will need a different type of shoulder replacement called reverse shoulder arthroplasty, and I'll show you some example. So this is the anatomical shoulder replacement which you would give for a normal glenohumeral arthritis, where it is anatomical. So instead of the ball, you put a metallic ball, and instead of the socket, you put a plastic socket. And that is good when you just have arthritis and the rotator cuff is intact. But what we have found is when the rotator cuff is not intact, better results are obtained from a reverse shoulder replacement. So you now make the scapula as the ball, and you make the head of the humerus, the arm bone, as a socket. So this is a reverse shoulder replacement. Now that is the treatment of choice. This came accidentally about 20-30 years ago. It started in France. They started doing this reverse shoulder replacement, and they found it is a great success. And now quite a lot of centers are only doing, or they are doing more of reverse shoulder replacement. It's a more forgiving procedure. But generally, if the total shoulder replacement of the anatomical is done when you're younger, whereas the reverse shoulder is done when you're older, and this one is done when there is total shoulder anatomical higher demand, where there is a less demand. So if the older the patient, reverse shoulder is better; younger the patient, anatomical shoulder replacement is better. And one of the reasons for this reverse shoulder is when you need to move the center of rotation. Here, the center of rotation is here. And if the center of rotation is here, the deltoid, as I said, if the small muscles are damaged, the deltoid pulls the ball and it starts hitting on the acromion. So because of that, you need, and in this situation, if you do this, what you're moving is the center of rotation biomechanically, you're moving it inwards, and this becomes the ball. So this part, the socket, is moving around this ball. This becomes the center of rotation, and it improves. Better biomechanics are resulted. So here you can see a rotator cuff arthropathy. The shoulder has moved up. It is causing some osteosclerosis here. And you can see a reverse shoulder arthroplasty where there is a ball to the glenoid attached with screws, and there is a socket to the top end of the arm bone, and that is fixed with cement into the arm bone. Whereas this is a normal shoulder replacement. There is arthritis here, but the rotator cuff is intact. It is not moved up, and you could do a normal shoulder replacement with a metallic ball with a stem into the marrow cavity and a plastic socket into the glenoid. So next, let's look at dislocations. So in dislocation is when there is no more contact between the ball and the socket. So you can have acute dislocations or chronic dislocations. Acute dislocations, what happens suddenly, and chronic dislocations is where there is multiligamentous laxity, and we'll come to that. So it is important for us to understand there are two spectrums. So on the left side of the spectrum is the sudden acute dislocation. So this is the rugby player or the rower who has a dislocation, and that comes on the left side of the spectrum. So it is traumatic. It is usually in one direction, and the surgery may be bank cart repair or surgery is needed. But on the opposite side of the spectrum is the ambry. So here is the TUBS. The opposite end of the spectrum is ambry. Ambry is atraumatic. There is no particular trauma. There was no particular rugby injury or something. They are just lax. It is multi-directional. It's not just in one plane. It is lax in all planes. And it could be bilateral. Both the shoulders could be affected. Surgery is less required, and usually rehabilitation is enough. If at all rehabilitation doesn't work, there's something called the inferior capsular shift, and I'll show you that can be done. But it is important, if someone who has a dislocation or instability, we're able to identify whether are they the TUBS or are they the ambry? Is it traumatic and unidirectional, and or is it atraumatic and multidirectional? I'll show you some examples. Now, here is a traumatic dislocation. You can see the X-ray. You can see this is the clavicle. This is the acromion. This is the glenoid. This is the head of the humerus and the shaft of the humerus. The ball should be sitting in the socket, but obviously it is not sitting in the socket. This was a rugby injury. And you can see on the axial Y view, you can see the ball is sitting in the front, whereas the scapula is away. So the ball is not sitting into the socket. And yes, it comes into A&E, and we can reduce it by different maneuvers. Sometimes general anesthetic may be required. And here we have reduced it, and the ball is now sitting inside the socket. You can see the clavicle and the acromion. And this is the lateral or the scapular Y view. The scapular Y view is because you see the scapula in a Y shape. And this is the glenoid, and you can see the head of the humerus sitting into the glenoid. But this is the opposite end. So earlier what you saw was the TUBS, the traumatic. But here is the atraumatic. So this lady has got atraumatic, and this is the sulcus sign. You pull on the arm, there is contraction, and you can see the parts of the skin is being pulled into, which shows that this joint capsule is not tight, and you can actually pull out the shoulder, not completely out, but there is an instability. Now, they don't require surgery. They definitely require rehabilitation, and it's a complex type of rehabilitation they require. So this is the condition where there is no dislocation, but you can, if you just slightly pull and take an X-ray, this is what happens. And when you leave the arm, it goes back into place. So in a stress radiograph, you can see that dislocation, or when you see the sulcus sign, you're actually doing this and the skin gets sucked in. That's how you see the sulcus sign. Now, but in acute dislocations, if you're an elderly patient, yes, rehabilitation will help. But in younger patients, sometimes college students who have playing rugby or playing football, they have dislocations. There is, if you're less than 20 and you have an anterior shoulder dislocation, then you have a very high chance of recurrent shoulder dislocations. It'll keep on dislocating again. So some people who have that, their sporting activities decrease, so you need to help them. And yes, they may try rehabilitation, but if rehabilitation doesn't work, they may require surgery. So how to test whether there is an issue? So one of the tests is the apprehension test. So when they externally rotate the arm like this, keeping the shoulders abducted and taking the forearm into external rotation, they don't like it, and they will prevent you from doing it, and that is the apprehension. But on the other hand, if you put an arm in front of the shoulder and reassure them it is not going to come out and that your arm is there, then they will be able to externally rotate better. This is called the Job relocation test. So these are the tests to identify whether there is instability in the shoulder. In atraumatic, there it is in all directions it moves. So you can stabilize on the right hand is stabilizing the clavicle and the scapula, and the left arm is holding the proximal humerus, and you can move the arm forward and back, out and in, and you can see that there is general laxity. We look at laxity also later. So this is the ambry, the other end of the spectrum, not the tubs, the traumatic end. Now, this is also very interesting. Now, you may think this is not dislocated and the ball is in the socket, but actually, these injuries are missed. They are missed a lot because this is a posterior dislocation. Usually, in the rugby or rowing, they have an anterior dislocation. The ball comes towards the front. But here, this is a posterior dislocation. The ball goes to the back. And as I said, it is missed on a lot of occasions. It is missed because this happens usually after a fit. So a patient may have an epileptic fit and they fall down or something with the epileptic fit and the shoulder dislocates. After the fit, they are in a postictal sleep. So they don't pick up the problem in the shoulder, and then finally the shoulder becomes apparent, maybe sometimes even a couple of weeks after the problem. And sometimes even when X-rays are taken, it is missed because the AP view looks like it is in place, but it's not in place, and it's a very characteristic sign that we see here. Now, the normal shoulder, which we saw earlier, if you look at this on this image, you can see it is slightly eccentric. Whereas when we see this image, you can see it is not eccentric. It looks like a light bulb. So this is called the light bulb sign, where it is not like the normal shoulder. It is because the shoulder has moved. There is an internal rotation and a posterior dislocation. That is why you get the light bulb sign. And in that situation, when you take the true axial, you can see this is the socket here, but the ball is sitting at the back. So that's a posterior dislocation. And as I said, it usually occurs after an epileptic fit and it can be missed. So that's where the acromion, the clavicle, the coracoid, and that's the glenoid, but the shoulder is not sitting in place. Again, after you reduce it, it comes back into place. And again, it is important to do a scapular Y view or an axial view to ensure that the ball is sitting within the glenoid. Now, in multidirectional instability, it is a complex rehabilitation process. And this Lynn Watson, she is a physio from Australia. She has done amazing work. And she has provided, because her theory is that the arm bone, the humerus and the scapula are not moving synchronously, and the humerus is moving away from the scapula. So we have to get the humerus and the scapula, the shoulder blade, to move together. And this rehab takes sometimes 6 months to do it, is retraining the muscles of the scapula and the humerus to move in synchronously with each other, and then the shoulder can be. So it is a lot of strengthening exercise using bands and feedback into the scapula and the proximal shoulder. Now, looking at the surgery part, I said that in a traumatic anterior dislocation, and a younger patient, you may need surgery. There are different types of surgery possible. So I'll just show you two different methods. So this is what is known as the Latarjet method. The Latarjet method is, if you see here, so this is the ball and this is the socket. Now, it keeps coming out to the front. That is what happens in a recurrent anterior dislocation. So you take away, so this is the biceps tendon getting attached to the coracoid. You cut the coracoid here with a saw, take the coracoid and then place it in the front over here. By doing that, this tendon comes in front of the shoulder. This bone becomes a block in the front and the shoulder cannot. This is this glenoid. It comes in the front. So the head of the humerus cannot dislocate out. So that is a Latarjet procedure. And this is slightly the favored procedure. But the other one you can do is, the other one that you can do is the Bankard's repair. The Bankard's repair is this side view of the glenoid, and you can see the front of the glenoid is torn, so there is a labral tear, and there's a Bankard's lesion, and you can arthroscopically you can put sutures and tie it up. That is an arthroscopic repair of the Bankard. But the Latarjet, where you take a bony block, that has got far better results and less chance of recurrence. Sometimes in a multi-directional, you can do this, the capsular shift. You can tighten because there is generalized laxity. But if you tighten the front, in case the rehabilitation doesn't work, so you cut the front like a double-breasted coat, you make it a bit tighter. You put some screws with threads so that is suture anchors, and reposition it, and hopefully that should help. Now coming to the elbow, so we look at the two conditions in the elbow, the lateral epicondylitis, the tennis elbow, and the medial epicondylitis. So one of the ways to identify it is resisted wrist extension to elicit pain. So when you extend the wrist, they will complain of pain in the lateral epicondyle. And or otherwise you ask them to straighten the middle finger and you resist it, again they will have pain in the lateral epicondyle. Now, this identifies a problem, and then you identify. So it is on the lateral, on the outer side, that you have tennis elbow. It is not related to tennis at all. Some people who don't play tennis will get it, but it is popularly known as tennis elbow because the backhand that the tennis player does, that is what is blamed as the cause of the lateral epicondylitis. Now, again, this is a randomized controlled trial. So we looked at concentric and eccentric exercises in this trial, 120 subjects. They were divided into two groups. Eccentric exercises were 60 and the concentric exercises were 60. And the eccentric exercises were better than the concentric exercises. So here they do, so the patient is here. I showed you how they were holding a rucksack, but here what they do is hold a bottle of water. And like how in my rucksack you can change from one bottle of 1 liter, keeping one bottle of 1 liter water or 2 liters, here you can differentiate the amount you want to increase. You can fill it up with half a liter of water or 1 liter of water, 1.5 liters of water. So if the hand pulls it up, it is a concentric. That is, this muscle is contracting and lifting it up. Whereas while the bottle of water is lowered down, this muscle will be having an eccentric contraction. So you want eccentric contraction. So you use the other hand to help it to lift, and the bad hand only lowers it down. So the good hand comes along and helps you to lift it up. And as I seen in the first video that I showed you, the good hand helps to lift the weight up, and lowering down is only done with a bad hand. So this is when you have tennis elbow of the left elbow. So the good hand helps you to lift it up, and the bad hand allows you the up with the good, down with the bad. Easy way to remember. So for the good hand helps to lift, and the bad hand comes to lower it down. There is another way of doing these exercises. You can do it with resistance rubber bar. That is slightly more complex, but you know how to do it. But again, I've shown you a video of how to do it. So you hold my tennis elbow. I don't have tennis elbow, but assuming my tennis elbow is on my right elbow. So you hold the arm, the bar as it is, and then as you straighten it, you're pushing the left arm down, and then the right arm goes down so that it's an eccentric motion. I'll repeat it. Oh, sorry. Just for you. So holding it together, the left arm twists it, and then the right arm follows that twist. So that is all this does. But this is slightly more complicated to explain to patients. So the other one where I use a rucksack is what I usually, and the opposite of that can be, used for the golfer's elbow. So if you, or other way is you just ask them to use a normal ankle weight or any small dumbbell. And you can do the same eccentric exercise from the elbow, or you can do it from the wrist. So here you lift it with the good hand, give it to the bad hand, and the bad hand lowers it. So in this particular case, the left hand has got a problem. The right hand is the good hand. So the right hand grabs the weight, lifts it up, transfers it to the left hand, and the left hand brings it down. When it brings it down, it's when the eccentric. So you repeat it 15 times. You can also do that was with the elbow. You can same do it with the wrist. With the good hand, you hold the weight, lift it up, pass it on to the bad hand, and then the bad hand brings it down. And you repeat the process 15 times. The medial epicondyle is on the other side, the inner side, and similar eccentric exercises will help. Again, there is evidence to suggest that. Here you can do it again with the elbow. So with the good hand, you lift it up, transfer it to the bad hand, and with the bad hand, you lower it down. But you can see it is turned, it is a supinated position of the arm so that it is a flexor muscles. Same way you can do it just with the wrist without lifting it all the way up. But what you shouldn't do is, this is a lady who had golfer's elbow and had repeated steroid injections, and you can see the atrophy that has occurred after the repeated steroid injections. So steroid injections are not necessary, and it is very superficial and will actually potentially cause harm. So just exercises, the eccentric exercises are the best to do for these cases. Now, this is sometimes you may come across this case, so I just thought I will put this up. This is called the Parsonage-Turner syndrome. So again, this is a self-limiting condition. So this patient's problem is on the right side. Suddenly, he develops severe pain on the right shoulder area. And you can see he's got stiffness, he's not able to lift it. And when he's trying to lift, there is winging of the scapula here. But with time, it settles, and in 2 years' time, he regains his function. This is acute brachial neuritis. So the brachial, nerves just temporarily go out of action. This is an acromioclavicular joint dislocation, not a glenohumeral dislocation, but the clavicle here has dislocated. Again, it doesn't require any surgical intervention. This gentleman had about 2 weeks ago had a dislocation, but you can see how comfortably, you can still see the bruising, but how comfortably he is able to lift the arm without any difficulty. A little word about hypermobility. So here you can see there is a hypermobility in the elbow, there is overextension. So how do you classify it? There is the Byton score to classify it. There are 9 points, and 2 points are for the finger, little finger, 2 points for the thumb, 2 points for the knees, 2 points for the elbow, 2 meaning 1 on either side, and 1 point for the spine. If you have a score of more than 6, then obviously it is significant. So the little finger is, you keep the hand flat on the table. It has to be completely flat. And if you can lift the little finger more than 90 degrees, and the other finger shouldn't be lifted, you must understand the ring finger should still stay on the table. And if it is less than 90 degrees, you're not hypermobile. The next way is you take the thumb and try to oppose the thumb to the inside of your forearm. And if it comes, opposition is possible, that is 1 more point. If you can do it on both sides, 1 point for each. Knees, as you stand, it should be straight. It shouldn't go into recurvatum. If it goes into recurvatum as shown in this, there is a point for each. Same way in the elbow, you extend the elbow. If it goes into recurvatum or more than 0 degrees, then there is a point for each elbow. The spine, if you can bend forwards and place your hands flat on the floor, then again you have hypermobility. Now, people with hypermobility generally tend to have more musculoskeletal problems. So it's to encourage them not to do this, not to do these party tricks, and strengthen their muscles is important. Now, this is a interesting case. So this lady had an injury. She's 68 years old, had an injury, proximal humeral fracture. She had actually both humeral fractures. So it was decided to operate on her, and she had a shoulder replacement. This a hemiarthroplasty, not a total shoulder replacement, a hemi where only the ball was changed. So the ball was changed, and one operation was done on her. Unfortunately, she didn't do well, and she got infected, and you can see the shoulder is riding up. it was decided that that should be changed. So that was changed, and she had a reverse shoulder replacement. So from the normal shoulder replacement, it was now changed to reverse shoulder replacement. So the ball was onto the scapula and the socket was put onto the arm bone. Unfortunately, got infected again. And now the whole thing was removed, and they put a cement spacer there so that to control the infection. And then after about another 1 year, it was decided to reimplant another reverse shoulder to give us some mobility. And this, luckily, it didn't get infected, but she's got some arthritis in her neck. So this was a journey. In 2008, first fracture, 2009, painful left shoulder, replacement reverse shoulder, infection in the reverse shoulder, had surgery, further reverse shoulder, had reattachment of deltoid, so many different operations. Though it is very clear, there is, I said about so many trials, there is a Proffer trial. Proffer trial is proximal fracture of the humerus trial, which clearly says you don't need to operate this. You treat it non-operatively, even with a fracture, and they will do extremely well. So just by doing surgeries, we are not going to help these patients. So this is the same lady. On the right, she had one operation. Luckily, that went on well. She had the same fracture on both sides, but luckily the right did well, but the left didn't. Look at the number of scars she's got on her left shoulder, multiple scars like tram lines or train lines, and she has hardly any movement. That is all she can move, her shoulder. She's got 100,000 pounds worth of equipment in her left shoulder, or has had in the left shoulder, but there has been no benefit from it. So just because we have spent money, just because we are doing operation, doesn't necessarily mean we will have the best benefit. Thank you so much for listening.